My slides are online, so I was not going to go over them again, but there's one slide that is, I can't, it's worth 1,000 words, and I don't have 1,000 words today, so I don't have time. So I wanted to start today by introducing the community that I work with. So I work in the state of Alaska. I'm actually based in Anchorage, and I service all of the Alaska Native population throughout the entire state through a telemedicine program. So I'm going to kind of challenge you a little bit to rethink what you think of as a healthcare provider or practitioner. We've had to become kind of creative in Alaska because the providers are not where the patients are located. Here. So just real quick, the Alaska Tribal Health System is actually a conglomeration of about 30 different tribes across the Alaska state. We serve about 180,000 Alaska Native American Indian patients. We have 130,000, excuse me. 70% of those patients live in a rural area. 70% of our providers are not in those areas, okay? Our average village has about 350 residents, and we have 6 regional hospitals that serve the entire state. Most of them are only very small, like 5 to 10 beds, if that. And then we have a larger hospital in Anchorage, which we'll talk about in a moment. There's 180 small village health centers with a very unique role for about 550 community health aid practitioners. And those are folks that actually are hired by their own village community. They are a resident in that community, and they are trained to become the hands-on provider for their area. They work out of a very small, little, tiny clinic, and you would be impressed by how much technology they may actually have in that clinic in order for them to become physician extenders. They go through a series of 4-week courses where they actually go through, is it automatically going forward? Okay. Where they actually they get training, basic training in Anchorage on basic healthcare. They have an electronic community health aid training manual that's sort of a guide for triaging patients and providing care. And we have that available electronically. They have those on iPads in their area. So those are the hands-on people right in the community. We can talk more about that if you have questions. The Alaska Native Medical Center is actually the tertiary care and specialty care services for the entire state. So if you're looking at a primary care doctor, that person isn't available in your region, and surely you don't have a specialist in your region for the majority of our patients. So one of the things that we had to do, if you look at this is the one slide I want to show you, then I want to turn them off because I think they're very distracting, is I want you to think about the size of Alaska and the rest of the United States. I think sometimes people think that it's exactly like it shows on one of those little maps where it's really tiny, like the size of Hawaii. We're a little bigger than that. And so each one of these black dots is actually one of the villages that we serve. We have a hub and spoke kind of means of referral system. So each of those tiny little dots refer into I need to turn this off now. I don't know how to turn it off. Yeah, thanks. Each one of those little dots is a referral area. They refer into a primary care hub, and if they can't take care of it, then the travel goes to Anchorage. That type of the average cost of travel is about $900 on average for just the patient. We're not talking about the lodging or an escort. And if you also think about it, that's generally a 3-day trip for maybe a 20-minute visit. Not very efficient, and also a huge barrier to access to our patients. So my team was about 13 years ago was tasked with a number of other folks to create a means of providing access to these patients in rural areas. And so what we came up with was something that very much suited what they needed, and that was a telemedicine um, program. Most of the rest of the United States, actually, for telemedicine relies on video teleconferencing, where you actually have a live visit with a patient, and you do it all virtually, and people can see each other. That wasn't an option for the state of Alaska because our internet connectivity is so bad. And not until the last 2 years is that something that's even possible or scalable or spreadable. It is now, and it's going like gangbusters. But prior to that, we used what we call store and forward technology, which is a means of capturing patient data using various peripheral equipment, like it could be an ECG machine, it could be vital signs. We have an otoscope. We have a lot of ear issues in our population. Like stethoscopy. It could be any number of types of peripheral devices that capture clinical data on a patient, and that's something that the community health aide can use and then send on to the primary care provider for evaluation and treatment. The patient doesn't actually physically have to see the primary care doctor to do this. It can be done asynchronously. That can then also be forwarded to a specialist for care. So just to give you a quick example of how that technology is used, we have quite a few ENT specialists, and like I said, we have a lot of ear issues with our population. And if a patient, actually a child, wanted to have a cochlear implant, they would physically have to move to Anchorage to be seen because they needed follow-up that frequently. Now they can just take a quick image of the ear. The provider can see from Anchorage exactly what's going on with the patient, and they can stay in their community where they should be. So we've really been able to provide care closer to home. We talk about the volume of care that we're providing. We have about 30,000 cases a year across the state, which is a huge number. We have to train people on how to use that equipment. We can talk a little bit about how we design that equipment so that it actually is tailored toward the community healthcare provider. The provider, the community health aides, actually use a touch screen. It's color-coded. It's very simple for them to use the equipment. They have it on a cart. Everything's right there. We train them. We train them how to keep themselves trained. We train them on the IT side of things, how to maintain the equipment, that type of thing. Try to keep it very, very simple. On the provider end, it's a little more catered towards something that looks like Outlook. So it's very easy for them to be trained as well. We have about a 20% turnover in our staff we have to train every year. That's a lot of providers that you have to continue to train when you're talking about 1,500 providers. So it's a model that seems to be working very, very well for us. It's quite successful. Our equipment's actually deployed in 13 different countries and throughout the US and at least 17 states that I'm aware of, besides just Alaska. So I also wanted to touch base real quick because this is a forum about education, and I think it's important that community healthcare providers actually know how to leverage technology for their work and their models. And so we try to continue to train them on what's the best use of different types of equipment and technology that might be available to them. And then some of the barriers for using that. There's licensing issues, there's credentialing issues, there's all kinds of other bits and pieces that go with that, as well as payment models. So we can address those if you have questions about that. One last piece of information is we do use a lot of our video telemedicine technology to do training, because not only can you not provide care to those rural areas, how do you keep those people educated? So distance learning is a real big thing for us. We use it quite often. We also have care models where we have dual physicians on the same video teleconference so that we have knowledge transfer between different providers. HIV is one that we just stood up recently. Pain management is another one where our primary care providers say, I'm not real comfortable handling this type of situation, but I do want to learn how to do this better. They don't see very many HIV patients out there. So we'll have a HIV physician specialist who is in on the conference visit with the patient, and there's a mutual collaboration between the patient, the primary care doctor, and the specialist. And that seems to be working very, very well for us in a number of different services. So with that, I'm hoping that you have lots of questions for us. And I will go back to my seat.